Hi, everyone. We're going to get started. Again, I'm Sharon King. I hope you all are having a good day. I hope you've been enjoying the sessions and learning a lot. And I'm really pleased to welcome our next speaker to the stage. Dr. Alexander King is an assistant professor of pediatric anesthesiology at Cincinnati Children's Hospital. He completed his anesthesiology residency training at Cleveland Clinic and earned his medical degree from the University College Cork in Ireland. His clinical interests include fetal anesthesia and anesthesia for rare diseases. Outside of work, he enjoys playing video games and spending time with his family. Thank you so much for being with us today, Dr. King.
Thank you for that introduction. So I was asked to come speak today on anesthesia complications for patients with MPS. As was mentioned previously, my name is Alex King. I'm one of the assistant professors at Cincinnati Children's. So the goals of this talk are to present an overview of the specific anesthetic complications that we see in patients with MPS and to discuss supporting literature and risk mitigation strategies, which include things like pre-op planning, imaging, evaluation, and then some intraoperative techniques. And the hope is that this will provide patients and their families with the information needed to make informed decisions about your anesthetic care in the future. So anesthesia involves three components: analgesia, amnesia, and hypnosis. And what that means is we keep you asleep, comfortable, and safe. Believe it or not, asleep and comfortable are the easier of the three. To keep you safe, we have to understand what the complication risks are and how we can mitigate those risks. There are two types of risk. You have baseline risk, which is the risk in the general population, and it's things like injury to a vein when placing an IV or a reaction to an anesthetic medication. Patient-specific risk is going to be unique to individuals and their conditions. Within MPS, that risk will vary between the types due to the way those types manifest, but even more than that will vary between individuals due to differences in residual enzyme function, response to enzyme therapy, or hematopoietic stem cell transplantation. However, classically, MPS types 1, 2, 4A, and 6 are going to be the highest risk for anesthetic complications. When you look at the literature, historical rates range almost frustratingly between 9 and almost 35%. More recent publications, like this one from Moser et al. In 2025, which was out of UCSF Oakland, published a rate of just over 1%. And that was looking retrospectively at 600 anesthetic cases for all MPS types. One of the conclusions from that paper was that the centralization of anesthetics to their experience center likely contributed to this improvement in complication rates. So what are the specific complications that we see? Well, as with all things MPS, it's due to buildup of glycosaminoglycans throughout the body, and where those depositions occur leads to the features and the potential complications that we see. This image here is from a paper by Walker in 2013 and has a large number of considerations, but they fall into three main categories: airway, the cardiopulmonary system, and the neurological system, and that's where we'll focus our talk. So patients with MPS are known to have difficult airways. The exact incidence also ranges depending on the publication that you look at, but a representative number would be difficult mask ventilation of around 14% and difficult intubation of almost 25%. What we do know for certain is that difficulty increases with age, and it's due to a variety of factors, things like a large tongue, tonsils, and adenoids, limited mouth opening, redundant oropharyngeal tissues, and restricted neck extension, either because of prior fusion or because of atlantoaxial or cervical instability. You can see in this image are the three axes which we traditionally have to align in order to visualize the structures to intubate a patient. And anything that makes alignment of those axes challenging can result in a difficult airway. So what can we do about this? Well, it's generally recommended that the first line approach is with some sort of indirect device by a skilled practitioner. That could be a video laryngoscope like the McGrath pictured here, or it could be with a fiber optic scope, which is pictured here. LMAs are an alternative device which is not technically an intubation, but can be used to appropriately ventilate and oxygenate a patient, and is also used as a rescue. It's part of the American Society of Anesthesia's difficult airway algorithm. The UCSF publication actually noted that they used LMA in 77% of those 600 cases successfully. Additionally, at academic and tertiary care centers, we have skilled colleagues such as ENT surgeons and interventional pulmonologists who, if they're not already involved with the case, if the airway is particularly challenging or concerning, we will make them aware and make sure that they're available should the need arise. Postoperative respiratory insufficiency is a common occurrence in patients with MPS. It can be due to a number of factors. There's a high prevalence of airway obstruction and obstructive sleep apnea. This combines with a restrictive lung disease due to chest wall changes, and chronic hypoxia and hypercarbia that are all acutely worsened in the perioperative and post-anesthesia period. The end result is that you may require some form of non-invasive positive pressure ventilation, such as CPAP or BiPAP, which is pictured here. That can be used for a short period of time, or if it's needed for a longer period of time for recovery, sometimes ICU becomes the more appropriate setting. Cardiac involvement is noted in all types of MPS, but in particular types 1, 6, and 2. The progressive involvement with the heart leads to a number of things: a deposition in the muscles of the walls of the heart and a hypertrophic cardiomyopathy. Deposition can disrupt the electrical conduction of the heart and lead to dysrhythmias. Valve infiltration occurs and can lead to aortic and mitral regurgitation as well as stenosis, although across all types, the most common is mitral regurgitation. And there's coronary infiltration, which can decrease the perfusion to the heart. And as I previously mentioned, the chronic hypoxia and hypercarbia can combine with valvular lesions to predispose patients to pulmonary hypertension. So how can we mitigate the cardiac risks? Well, echocardiography preoperatively is essential. This allows us to get a sense of the function of the heart and the valves. And based on that information, we can target certain heart rates and blood pressure goals. In cases where we are particularly concerned or want to watch more closely, we may recommend placing an arterial line, which is a small IV that goes in an artery in the wrist or the arm. That allows us to monitor heartbeat and blood pressure from second to second, as well as obtain labs, measure arterial carbon dioxide, and even calculate cardiac output. Neurological injury is the third anesthetic complication that we'll discuss, and it's one of the more feared complications because of how essential an intact neurological system is to daily function. Some of the clinical findings which we find relevant, and you may hear mentioned, are things like atlantoaxial instability, where the head meets the neck, cervical spine instability, which is the neck above the shoulders, kyphoscoliosis, and in particular gibbous deformity, which is pictured here, and spinal stenosis, which occurs at all levels of the spine. The risk of neurological injury is not just hypothetical. There are numerous case reports. These are just two. Drummond was a patient with MPS type 4A who experienced lower extremity paralysis after a combined lumbar epidural general anesthetic. And Tong was another case report on a patient who had spinal cord infarction at the thoracic level after undergoing a cervical spinal surgery. At Cincinnati Children's, we had our own neurological complication in a patient with MPS type 1 that led to the creation of an algorithm, which I'll present a little bit later on here. So what can we do? Well, it's generally recommended to avoid epidural anesthesia. Although the exact mechanism of injury is not understood, there does seem to be a correlation between the use of epidural anesthesia and the risk of neurological injury. Careful positioning is crucial. We'll often have, if able, these patients position themselves on the operating room table so that we know that they can tolerate the position and that it's comfortable before we go to sleep. Preoperatively, we'll obtain imaging, including scoliosis radiographs and cervical spine flexion and extension radiographs. And then we can use IONM, which I know has been discussed previously. Intraoperative neuromonitoring, or IONM, is a technology that's used during general anesthesia to assess the integrity of nerve signals between the brain and the body. It comes in a variety of flavors, but the most common ones you'll hear mentioned are SSEPs and MAPs. SSEPs, or somatosensory evoked potentials, measure the integrity of the signal from the periphery, from the sensory parts of the body, up the spinal cord and to the somatosensory cortex of the brain. And MEPs, or motor evoked potentials, in almost the opposite direction, measure signals from the motor cortex down the anterior part of the spinal cord to the muscles that they control. So why monitor? Well, as we mentioned, neurological system is essential for movement and sensation, and it needs to be intact for everything we do. IONM provides a real-time awareness of a potential problem so that we can address things like positioning or blood pressure. We can look at labs and make sure that the oxygen carrying capacity of the blood is adequate. And ultimately, if we can't resolve the change in IONM signals, then sometimes we have to have a discussion with the surgeon and abort the case in order to avoid permanent neurological injury. Just a little note about IONM and anesthesia. The standard gas anesthetic, which most people receive, which keeps them asleep, interferes with the ability to measure the SSEPs and MEPs, motors more than somatosensory. What this ultimately means is that you may require a total intravenous anesthetic, which is a combination typically of propofol plus one other agent like ketamine or remifentanil. You still remain asleep and safe and comfortable throughout the procedure. The only difference is that all of your anesthetic is going through a vein, through an IV, and we're then able to monitor those evoked potentials. Does IONM help? Candiel et al. Published in 2020 out of Cincinnati Children's a novel evidence-based care algorithm. So what they did is they created an algorithm that determined risk, and that was based on degree of kyphosis, less than or greater than 60 degrees, duration of surgery, either 60 minutes with a kyphosis greater than 60 degrees, or 90 minutes with kyphosis less than 60 degrees. And out of 38 patients they applied the algorithm to, 21 qualified for IONM. Of those 21, 3 or 14% had some change during the procedure that necessitated an intervention. And importantly, 0 of those patients had any long-standing neurological deficits. So what this tells us is that this algorithm appears to be useful in determining whether or not IONM is necessary, and that regardless of if you get IONM or you do not, the anesthetic appears equally safe. This is the algorithm that was published in that article, and we still use it today. Just to break down some of the key elements of it, it's a multidisciplinary effort starting 28 days or weeks before your surgery. It involves genetics, anesthesia, the IONM group, spine surgeon, your operative surgeon, and a radiologist. Once the surgery is scheduled, surgery places an anesthesia consult request, which goes to our anesthesia nurse practitioner, who contacts the caregivers to obtain a pertinent history, including the most recent imaging. If that is not recent enough, then we order new imaging, and that is combined with input on surgical length and surgical risk to determine if IONM is necessary. Ultimately, you'll fall into one of 3 groups: a high-risk group, a low-risk group, or a medium-risk group. The high-risk group receives full neuromonitoring. The low-risk group does not need any neuromonitoring. And the medium-risk group is evaluated on a case-by-case basis. An example of medium risk would be, for example, a patient who had previously sustained a neurological injury but was coming for a procedure that was not 60 minutes. That might be a case where it would be warranted. And I think, as was alluded to earlier, the reason we don't use IONM on all patients is because it does take time to set up. 15 to 20 minutes is absolutely a reasonable amount of time. We have to apply between 20 and 30 subdermal electrodes and then obtain baselines. And if your procedure is 30 minutes, and a 20-minute addition to that is almost doubling your time under anesthesia. So I know we talked about quite a bit here. I just want to summarize that anesthesia is high risk for patients with MPS. The complications tend to involve the airway, the cardiopulmonary system, and the neurological system. One of the things you can do when possible is obtain your anesthetic care at large centers with MPS experience. And IONM is a useful tool for detecting neurological changes as they occur in high-risk situations, but just because it's not indicated, if it's not, does not mean the anesthetic is less safe. Thank you.